All right. Hi, everyone. My name is Iyah Totounji. I am a medical student here in the US, and I'm presenting a case report on an acute inferior STEMI in a young male with factor V leiden mutation, testosterone-induced hypercoagulability. Here we have a little bit of background. STEMIs in young adults are rare, encompassing only about 2 to 10% of all myocardial infarctions. These patients typically don't have the usual risk factors like diabetes or hypertension. Instead, it's more non-traditional factors that tend to play a role. In this patient, two particular things stood out, which was the presence of a factor V Leiden mutation, which tends to be more prevalent in Northern Europeans, as well as testosterone therapy, which has been linked to a twofold increased risk of venous thromboembolism and creates a prothrombotic environment. The combination of these two is what made the case a little more unique given the patient's age as well. The case presentation is as follows. We have a 27-year-old Middle Eastern male who presented to the emergency department with 2 days of substernal chest pain radiating to his left arm. On arrival, his blood pressure was 152/93 and his pulse was 76. His history was notable for hypogonadism, treated with intramuscular testosterone injections every 2 weeks, as well as dyslipidemia with an LDL greater than 200. On the initial emergency assessment upon arrival, his vitals were stable. An initial EKG at around 6:42 p.m. showed minimal ST elevation, but this was ruled out as a normal early repolarization pattern. Around the same time, his troponin was elevated at 2.07, minimal elevation, but still there. And the echocardiogram that was done was unremarkable. Throughout his time in the emergency department and approximately 4 hours prior to his initial presentation, his troponin had risen further to 3.21 at around 11 p.m. And his EKG, which was done not long after the troponin was obtained, showed ST elevations in leads 1, 3, and AVF with reciprocal depressions in lead 1 and AVL. These findings were indicative of an inferior myocardial infarction. Following the second EKG, the patient was rushed to the cath lab for a percutaneous coronary intervention. The angiogram revealed a 70% occlusion in the proximal right coronary artery, which was later found to be caused by a platelet-rich clot, as there was no visible atherosclerotic disease on imaging or during the angiogram. A balloon angioplasty restored TIMI-3 flow, and IV heparin was started. At this stage, the physicians opted for conservative treatment and no stent placement due to the age of the patient. And as you can see here, there are a few diagrams of prior to, and then after the angioplasty or the angiogram. All right, moving on to day 2. On day 2, he was admitted to the ICU on continuous heparin. At this time, the patient was clinically stable. His troponins had peaked to around 57.5, and his team continued to closely monitor the anti-10A levels to guide his heparin therapy. An EKG, as you can see here, was performed around 7 a.m. that day, which showed possible signs of reinfarction or refractory thrombosis. However, given the fact that the patient was stable, no further action was taken. On day 3, overnight, the patient had substantial chest pain that was not relieved by any pain medication. His troponins, as you can see here, were trending down at around 35.8. The first EKG performed that morning around 5 a.m. showed minimal changes in leads V1 through V4. However, the severity of his pain raised concern for ongoing infarction. A second EKG, as you can see here, was completed approximately 4 hours later, around 9 a.m. that day, which showed evolving changes, prompting the decision to return him to the cath lab for further evaluation. During his angiogram, There were no major changes in the partially occlusive thrombus that was initially retained following the first angiogram 48 hours prior. Given his age and clinical picture, the team opted for continued conservative management with heparin and dual antiplatelet therapy. He was presumed to have post-MI pericarditis, which was the reason for the chest pain, and treated with colchicine as such. On day 4, the patient began to develop severe thrombocytosis with values greater than 850,000. This was thought to be due to abrupt discontinuation of testosterone therapy upon hospital admission and inflammation due to the MI. Hematology was then consulted, and a second echocardiogram was obtained, which then revealed mild inferior wall hypokinesis. Given the state of the patient, the team now planned for a third angiogram. On day 5, the third angiogram was performed, which demonstrated a worsening thrombus in the right coronary artery. A drug-eluting stent was placed, and once again, successfully restoring TIMI3 flow. And as you can see here, it was now at 80% occlusion from the 20% that they had seen in the last 24 and 48 hours. Following the angioplasty, the patient was transferred to cardiac telemetry, and the continuous heparin drip was discontinued. However, his dual antiplatelet therapy was maintained. At this time, his troponin level continued to trend down at 12.9, and approximately 3 hours following the discontinuation of the heparin drip, the patient began to develop pain over the right wrist and forearm, where radial artery access had been attempted during the first angiogram. Later that night, an upper extremity arterial duplex imaging was done and revealed a complete radial artery occlusion with collateral reconstitution distally. At this point, IV heparin was restarted temporarily. And it was at this point that his cardiology team was left with more questions than answers. They were presented with this young male with consistently atypical STEMI presentation, no sign of atherosclerotic disease, and clear signs of severe hypercoagulability. Some of the physicians believed that his hypercoagulable state was due to the testosterone therapy, while others disagreed, and so a consensus was not met. On day 6, the patient remained clinically stable, and the decision was made to transition the patient from IV heparin to oral rivaroxaban, in addition to the dual antiplatelet therapy. He was also started on a high-intensity statin as standard of care and was discharged with close cardiology and hematology follow-up. In the upcoming weeks, some clarity was provided regarding the patient's atypical presentation. Shown here are the results of the hematology workup, which was remarkable for a factor V leiden mutation. Once these results were obtained, it was believed that the patient's hypercoagulable state was secondary to the factor V leiden mutation, as well as the hormone therapy, which, as I had mentioned, already has proven to induce hypercoagulation. In later discussions, and before I get to this, in later discussions, it was revealed that the patient had symptoms of a deep venous thromboembolism approximately 8 months prior, presenting with your standard swelling of a unilateral calf with pain and warmth and overall erythema as well. However, it resolved on its own, and the patient did not seek care at that time. This further highlights the longstanding hypercoagulable state that this patient most likely had. Now, on the etiology and pathophysiology, the case illustrates a multifactorial cause for that hypercoagulable state. And just a quick overview of the pathophysiology involved is we have a factor V leiden mutation, which is an inherited thrombophilia. This leads to resistance to activated protein C. This increases the risk for both venous and arterial thrombosis and is strongly associated with thromboembolic events when paired with other risk factors, as we have now seen in this patient. Additionally, the testosterone therapy can increase hematocrit, platelet activity, and vascular tone, allowing for a prothrombotic state and abrupt withdrawal, which can cause reactive thrombocytosis. And finally, the dyslipidemia and iron deficiency anemia would lead to the highly atherogenic environment and worsened endothelial dysfunction. Together, these factors most likely contributed to the STEMI without atherosclerosis. Management and clinical considerations. For this patient, the management followed standard structured ACC and ESC acute coronary syndrome guidelines of rapid recognition, anticoagulation, and early PCI, as well as discharge pharmacologic guidelines. However, this case shows that protocol-based management may not be enough when hypercoagulability is the driving factor. Conservative therapy failed, and only invasive stenting restored stability in the patient. Now, in regards to the implications for practice, this case did highlight the importance of considering inherited thrombophilias in atypical STEMI presentations. Additionally, it showed that although levels were monitored and within normal ranges, testosterone therapy can significantly increase thrombotic risk in predisposed patients. It also highlighted that management must be personalized for each patient, as the ACS guidelines do not fully address all aspects of patient care with an atypical presentation. And specifically in regards to the inherited thrombophilias, on initial presentation, the hematology consult highlighted that they believed there was no hematological aspect to this patient's case, which was then proven wrong by the factor V leiden mutation. So although the majority of patients are of Northern European descent, this highlights the case of looking through every patient's medical history and identifying any potential causes, including hematologic causes, for a case like this. And just to conclude, this case in particular highlighted that young STEMI patients may have hypercoagulable causes rather than the standard diabetes or atherosclerosis being the cause for the STEMI, and that genetic and hormonal risks must be recognized early on in treatment to help guide treatment plans. And finally, the importance of flexibility in treatment cannot be understated due to a case like this, where the patient was 27, young, active, healthy male, had no predisposing causes and no atherosclerotic burden on imaging, yet continued to have refractory thrombosis and had shown a prior history of thrombosis. And that's it. I am happy to take any questions.